Assalamu alaikum. I am Dr. Naharum Ivy Haidar Choudhury, Associate Professor of Pediatric Cardiology Department of National Heart Foundation. It's an honor, and we are privileged that the neglected part, the structural heart disease, which has given attention this large scale. And for this BDECHO session, we have to acknowledge this, and thank you. And today, we know that mother is the best friend of a fetus. And next to that, a physician can take place by doing a fetal echocardiography and can ensure a safe, secure perinatal birth. So today my topic is, hello mom, it's me. We know the indication of fetal echo, just discussed, I am recapitulating this. The maternal, paternal, or sibling, if anyone have congenital heart disease, or mother have any systemic disease, like diabetes mellitus, lupus, infection, drug, or assisted pregnancy, or have thick knuckle translucency, extracardiac anomaly, abnormal finding on first trimester, or having twin pregnancy or arrhythmia, fetal echo should be done. So it should be done on second trimester, 18 to 24 weeks of pregnancy, and the baby's position is very important. Sometimes baby is not in a suitable condition. We have to tell the mother to walk or to evacuate or blood empty. And then we have to do in 2 or 3 times attempts. Sometimes we have to abandon the procedure. So what congenital heart disease prior to birth is important. Number 1, prenatal counseling, very important. Number 2, delivery at an experienced cardiac center, and improved postnatal status and outcome in certain critical form of congenital heart disease. And all these helps to reduce the perinatal death. So I have taken 3 cases. Now I'm going to present my first case, and this case. She came to at 25 years, having 21 weeks of amenorrhea, having gestational diabetes, and anomaly scan showed that severe RV systolic dysfunction, and they referred the patient for a fetal detailed echocardiography. And we started the appointment, and it is the we determine this is the spine, and we see the stomach and aorta is on the left side, and IVC and liver, right part of the lobe is on right side. So this is cytosolators. And next to one space above, we get the 4-chamber view. And if we see that 4-chamber view here, if we see this 4-chamber, then this is the left atrium. And if we see why this is left atrium, because the pulmonary vein is entering into the left atrium, and this is right atrium because there is morphological right atrial morphology, broad base, and that pattern foramen ovale, this is on the left side. And next to that, the AV valve, if we see that, I don't know why it is not moving. This is the tricuspid valve, which is apically placed, and there is moderator band, and it is triangular in shape. So this is tricuspid valve. So left atrium is connected with the right ventricle, so AV discordance. And if we see this right atrium is connected with left ventricle, this is the mitral valve because it is basally placed, and LV is elliptical shape, and the interventricular surface is smooth. It is not moving. So, and next to that, the outflow tract, and outflow tract, if we see the LV is giving rise to the great artery, which is bifurcating. So this is pulmonary artery. And if we see there is no obstruction, it is laminar flow. So there is LV giving rise to pulmonary artery. There is ventricular arterial discordance with no obstruction. And if we see that there is RV giving rise to aorta, so there is RV to aorta, so AV ventricular discordance. And then next to that, great artery vessel view, 3 vessel view, and the aorta is anterior and left to PA. So there is left L malpost great artery. And if we compare this ventricular function with LV, then we can see that RV is moderately severe RV systolic dysfunction. And we know that in corrected TGA, it is usually associated with TR. There is moderate to severe TR. And sometimes corrected TGA have atrioventricular AV block, but in my patient, it is regular and heart rate is normal for the gestational age, which is 144 per minute and regular in nature. So final comment is situs solitus, levocardia, corrected transposition of great artery, moderate TR, and heart rate is 144 per minute regular with moderate severe RV systolic dysfunction with no pericardial effusion. So I want to end with that when life puts you in tough situation, don't say why, just say try me. Thank you all.
Nenuma, did you see the hyperechogenic, excuse me? Did you see the hyperechogenic spots?
In RV?
No, they both, see there were multiple hyperechogenic spots. What are they? Anyway, I noticed them. So there are multiple hyperechogenic spots. If there is a single hyperechogenic spot, you think of congenital heart disease. But when there are multiple, you think of the intrauterine septicemia. The child must have got the infection, and that's how, they can have hydrops fetalis secondary to that. So you have to suspect that.
Yes.
Okay, thank you.
That RV dysfunction, and I think next to this, that will happen. Thank you, ma'am.
It was a great learning. Thank you, Dr.